So good evening, everyone, and welcome to our webinar from IMG to GP, Navigating the Pathway in the ACT. So this webinar is part of a two-part series, with today's webinar aiming to help international medical graduates navigate the pathway to general practice in the ACT and surrounds. The previous webinar was held last Thursday, and it was sort of tailored to practice managers and practice principals to understand the requirements involved in recruiting doctors from overseas. This is more aimed towards the doctors coming from overseas and what sort of path they have to sort of take to get to working as a GP in the ACT. So both will be available on the CHN YouTube channel. And you're welcome to share it with your networks. Together, we hope the series will support a growing workforce need in the ACT and provide some clarity as we share some information and guidance in one place. So before we get started, I'd just like to acknowledge the traditional custodians of the land on which we meet today and pay our respects to the elders past, present, and emerging. I also extend that respect to any First Nations people joining us today. So my name is Adnan Alam. I'm a part-time GP advisor at Capital Health Network, and I'm joined by our Quality Improvement Project Officer, Katerina, and our wonderful events lead, Kunal. So our guest speakers today are Chrissy McKee from Ahpra, and she'll be taking us through the pathways from IMG for registration information, AMC exams, recency of practice requirements, and the such. Then we've got Stuart Riley and Gail Nicholson from the Department of Health, Disability and Aging, who will discuss navigating Section 19AA, 19AB restrictions, DPA, area of need, 3GA, which is relevant to ACT residents, provider numbers, and the such. And then Dr. Laila Shah, who's an international medical graduate and a current RACGP registrar. She will share her journey with you, including the requirements from the AGPT, challenges faced, and her own and helpful tips that she has accumulated along the way. So just for housekeeping, all participants have been muted. If you have any questions, please ask it in the Q&A section, not in the chat box on the side panel. And we'll have a Q&A session at the very end. We're aiming to have about 20 minutes at the end for a more interactive Q&A as we go along. So without further ado, I'd like to hand over to Chrissy. Take it away.
Thank you. I'll just wait to share my slides, sorry. Thank you. So my name's Chrissy. I work at Ahpra in the international registration team. And my team, we manage the applications for all overseas qualified practitioners seeking registration in Australia, but we do have a specific team for IMGs because that is by far our biggest number of applications that we receive. And there's a number of different pathways that we receive applications from. So need dedicated expertise. Let's go to the next slide, sorry. I would also like to do an acknowledgement. I'm in Brisbane, which is in the lands of the Yagara and Turrbal nations, and I'd like to pay my respects to their elders past and present, and also extend any respect to Aboriginal and Torres Strait Islanders in the room today. So I'm just a bit of an overview for today's session. We're going to be talking about some of the pathways. I won't focus too much because we don't have much time today, so I might skip through a couple of slides. I've also got some information there for employers and authorised representatives, and then some just information about the registration process and recency of practice. So there are 5 established pathways for registration, which are available. Information is available on the Medical Board's website. This is where this screen grab has come from. Each of those tiles there, if you click on those tiles on the board's website, it will give some further information about the board's pathways. But specifically, competent authority pathways for those IMGs coming from the UK and Ireland and other comparable jurisdictions. And then we've got the standard pathways for IMGs who are coming seeking general registration here in Australia. And this pathway applies to pretty much any IMG who aren't eligible for the competent authority pathway, but aren't here to complete specialist training. The specialist pathway is open for IMGs who are have either close to qualifying with an international qualification, specialist qualification, or have an international specialist qualification, and are seeking, ultimately seeking specialist registration to work in their specific specialty here in Australia. One of the new pathways, which I'll talk to in a later slide, is the expedited specialist pathway. This is a new pathway that was commenced last year, and that's specifically for overseas qualified specialists who hold a qualification that the board has deemed to be substantially equivalent, and they can apply directly for specialist registration here in Australia. And the last pathway is the short-term training pathway, which is specifically for those IMGs seeking to do specialist training here in Australia. So there is a self-assessment tool on the board's website, which I've highlighted here. This self-assessment tool has got a series of questions which will help, that you can answer, and it'll help guide you to working out which pathway you'd like to apply for registration under. So specifically, the expedited specialist pathway is open for 4 specialties at the moment. More are expected to join shortly. General practice commenced about a year ago, and that's by far our highest volume application type that we're seeing. So the board has a number of qualifications it has assessed and deemed to substantially equivalent, and they've added it to their expedited specialist qualification pathways list. And so if an IMG has a qualification that is on that list, they can apply directly for specialist registration in general practice and the 3 other specialties there. IMGs will still need to meet certain requirements. They may need to complete supervised practice, and there's also a requirement for them to complete an orientation and cultural safety education. However, they don't need to do that before they can get specialist registration. They can do that as part of their specialist registration, and the board will impose conditions on their registration. There are certain exemptions that may apply, and that's assessed on an individual case-by-case basis. There is an evidence guide, a registration standard, and policy statements that have been developed which have more information about whether or not you need conditions and what the requirements are once you hold specialist registration. But essentially, you can seek registration to work and to complete that supervised practice, and then once you've met all those requirements, you can apply to have those conditions removed. You do not have to have a position to get registered on the expedited specialist pathway, but you can't have those conditions removed until you provide a position and you meet the requirements of the board. There is a different supervision framework that does apply to this pathway as well. So, sorry, my mouse is clicking. So there is specifically the standard pathway does require the IMG to complete an exam before they can apply for registration, and that's the AMC MCQ exam, which is the multiple choice online exam. Once they've passed that exam, they're eligible to apply for registration for limited registration. They can also go on to complete the second exam, the clinical exam, before registration. And if they pass that exam, they are awarded the AMC certificate and therefore can apply for provisional registration. They still need to work under supervision, and they still need to provide us with a position in order to get their registration. But once they are registered, then they just need to complete 47 weeks of supervised practice. Once that's satisfactory in general practice, they are able to then apply directly for general registration, provided they can meet all the other evidence requirements of the standard. General practitioners applying for registration to work in general practice must also need to complete a PESCI, pre-employment structured clinical interview, in order to apply for registration on this pathway. Sorry, there is a lag time. So the board has established a couple of has published a couple of videos on its website to help IMGs navigate to the right application type. I've shown the video here for competent authority pathway, but there are a number of other videos for the other pathways as well. This is because we've moved to an online system, and there is a requirement to complete what we call pre-registration questions, which helps you navigate to the right application form. But it's important that you answer those questions correctly in order to get to the right application form, and sometimes it might not be immediately clear. So we've published these videos to assist you in getting to the right application type. And secondly, the self-assessment tool that I talked about earlier is also a really good source to determine which application type you need to submit. These videos are available on the board's website at the link below, which will be provided in the slides later. So essentially, before applying, we recommend you to complete the self-assessment tool. All IMGs need to do primary source verification of their primary medical degrees, and they also need to do that for any postgraduate or specialist qualifications if they're applying on the specialist pathways. If you've lived outside of Australia over the age of 18, which most IMGs have, you'll also need to do an international criminal history check for any country you've lived in over the age of 18 for more than 6 months. And every jurisdiction you've been registered in, you'll also need to provide a certificate of good standing if it's been within the last 10 years that you're submitting your application. Some IMGs will need to provide English language evidence. There's a number of different pathways that you can meet on the board standard, which determines which evidence you need to provide. And of course, we'll need evidence of a position here in Australia. As I said earlier, for GPs wanting to come on applying by the standard pathway and also the competent authority pathway, will need to provide us with that PESCI. And if you're intending on applying by the specialist pathway, you will need to have evidence that you've gone to the relevant specialist college and completed that comparability assessment, or have had approval to work in a short-term training position. If you're working in an area of need, it's important to note general practitioners do need to have an assessment of their general practice experience. That can be completed by the specialist college, or it can also be requested within your application that the board complete that assessment. There is a requirement for a minimum of the equivalent of 3 years of experience in order to work in an area of need in general practice. So I've just given you a quick screen grab here of our new online form, because this is a bit different to what the application process used to be. And it's now completely online, but IMGs do need to create an Ahpra portal account. And then once they've done that, then they can go on and submit that application form. There is a requirement as part of this online account to have multi-factor authentication. So we do recommend that you have 2 devices at least while you're setting up this process. And there is lots of information on the board's website, like helpful tips and tricks, and a chat box to ask questions if you're having trouble. If you're still not being able to get through, then we do have a customer service team who is very happy to pick up to answer your call and to help you with any troubleshooting.
10 minutes.
Okay, thank you. I'll skip on. Some advice we say give to employers is how they can support their IMGs submitting applications is to be really clear about what they need to do and and when we need the information by. There are documents that employers will always need to complete in order to support applications, which are still PDF forms and can be prepared ahead of time and either given to the IMG to upload, or they can be emailed to us. So that's I've put out what those forms are there. And then once they have all those documents, they can submit their applications online. And once they've done that, they'll get a confirmation email. So you can always have, you can always get that evidence that they've submitted their applications should you need it. IMGs are able to nominate a third party through this process. And so we therefore recommend if they'd like to have someone speak on their behalf, that you provide those details to the IMG with their application. And lastly, there is a new digital process for verifying identity. It's done once the application is submitted, and it's done through a third-party process. And so IMGs will get a link. Once they've submitted their applications, they'll get a link to complete the proof of identity check, which is done through a different vendor, and they have a certain period of time, and there's a fee required to do that service. But there's lots of instructions on our website about this, and if there's any troubles, we can, give our customer service team a call, and they can help you with that. I'll just skip through here. So when to apply, we can accept applications up to 6 months before job start dates. But it's just important to note that once an application is ready for a decision, and so registration is granted, we can't register more than 90 days in advance. It's important to clarify the difference is because the national law actually has a provision that doesn't allow us to grant registration more than 90 days once it's been decided. So there can sometimes be some trouble when applications are submitted too early. They won't be able to then meet the requirements of the pathway they're on in the time that they're allowed, and might need to renew their registration. Just important to note that with recency of practice, it doesn't necessarily mean that they won't get registration if they don't have recency of practice. It just may mean the board will require a higher level of supervision or a longer period of supervision. So with recency of practice, the standard does outline how IMG or how applicants can meet recency of practice. If they don't meet recency of practice, depending on how long their gap of practice has been and what their level of experience has been before their gap, there's different evidence requirements required. And so with those applications, it's generally outside of Ahpra's delegation to the side. And so we would then provide whatever information that the IMGs provided about their recency of practice and provide that to the board. What we would expect with IMGs that don't meet recency of practice is that they may have to commence practice with level 1 supervision. And I think that's the end. I think I'll leave it there.
That was amazing. I can see that you've got a couple more contacts and other helpful tips to share. So I think at the end of the webinar, we'll be sharing around the slides and stuff as well, so that people can have access to this helpful contact list. But that was great, very informative. So we'll move on to our presentation from the department, and I'll hand over to you, Stuart. Thanks.
Thanks very much. Good evening, everybody. I'll start by highlighting that the department's website is a wealth of information for people looking for detail around both Section 19A and 19AB. One of the areas we constantly experience confusion is the relationship between registration and access to Medicare. So I think we've gone through the registration. People cannot access Medicare until they're registered. And so sections 19AA and 19AB and the operation of the Health Insurance Act really impact subsequent to that registration. Section 19AA was introduced at a time when the perception was there were too many doctors in Australia. The number of GPs was growing too fast, and general practice as a profession was looking to be recognised as a specialty. So what 19AA sought to do was firstly consolidate general practice as a specialty by requiring doctors who were registered after the 1st of November 1996 had to achieve fellowship before they could access Medicare. Those who were registered before the 1st of November 1996 were able to continue accessing Medicare, but the rate of payment was lower, so that they're referred to as non-vocationally recognised GPs, only have access to A2 and A7 items, which pay a lower rate than the A1 items that general practice or registered general practitioners, vocationally recognised general practitioners, can access. 19AA does, however, allow non-permanent resident doctors to access Medicare where they have an exemption to Section 19AB. I think there's quite often confusion and concern when doctors have been accessing Medicare, become permanent residents and then lose access to Medicare because they don't have their fellowship at that point. Section 19AB was established to direct international medical graduates and foreign graduates of accredited medical schools to the public hospital system. At the time that legislation came in, there was concern around access to workforce for public hospitals, given the issues that drove Section 19AA, the focus was on directing doctors towards public hospitals when they came in from overseas. That's still the case. However, a series of exemptions have evolved, and one of the side purposes of Section 19AB and 19AA is around distributing our medical workforce better across the country. At the time that this legislation came in, the view was that there were 4,500 too many doctors in metropolitan areas and around about 500 too few doctors in rural areas. Noting at the time we had 45,000 doctors nationally. Since that time, we're now approaching 120,000, which has seen growth much faster than the population. But there's still a concern around having the right type of doctors in the right locations so the community can access services. What Section 19AB does is effectively preclude an international medical graduate or a foreign graduate from an accredited medical school from accessing Medicare for the first 10 years after their initial registration. The basis for exemptions is determined by decisions the Minister has made in the past. So the Act allows the Minister to provide exemptions, but requires that the Minister in writing declare the basis for those exemptions. If you go to the Department's website and look up 19AB, it will take you to what are referred to as the legislative guidelines, and they outline the reasons that exemptions are given. The first amongst those is location, and so that reflects the focus on trying to get better access to medical services in rural areas, and that's the predominant basis for exemption. When the legislation came in, there was the notion of areas of workforce shortage or areas of need. It wasn't until 2000 that a tool for objectively reflecting that came about. Initially, it was a tool called the District of Workforce Shortage, which was built for general practitioners. It was adapted and amended to deal with all specialties. And then in 2018, general practice was taken out of it because there was concerns about the differences between general practice as a specialty and non-general practice specialties, which have significant involvement with hospitals and work in a very different way. That led to the development of what's known as the distribution priority area. The two changes that came in with the DPA was, first of all, looking at how patients move when they're accessing general practice. That geographic and activity data was used to build 827 general practice catchments, and the idea was that there's no point looking at to try and look at practices individually, overlook the fact that patients tend to move between practices, and they might have a practice they go to if they're feeling unwell at work, another practice that they go to for the family. And so it was trying to work out the geography that represents how general practice operates. The amount of Medicare activity through general practice is taken each year, and the population, with some adjustments for age and socioeconomic status, becomes a denominator. So the amount of activity is divided by a weighted population, and that gives a number. And that number is used basically to determine whether an area has a shortage of GPs or the community doesn't have adequate access. The reason for going down that path was doctors work very different ways to each other. And so to simply take a head count wasn't fair and reasonable. I think there's some parts or some rural areas where relatively small populations will have 20, 25 GPs, but none of them work full time. So the purpose of the measure was trying to understand how much access there is rather than counting the number of doctors. In using 19AB, the first thing that's looked at is the location the doctor is seeking to work at. If the result of the DPA analysis is that that GP catchment is below the level of activity that's the national average for MM2 locations, it's considered to be a distribution priority area, and exemptions to Section 19AB are readily available. If the DPA statistic is above that MM2 level, it's generally not considered to be DPA. However, that's become more complicated with a range of decisions related to a thing called the Monash modified model, which sees all catchments now, except for those in Monash modified 1, which is inner metropolitan areas, classified as DPA. If somebody is looking to work in an area that's not DPA, there are a number of grounds that can be considered in granting an exemption. The first of which relates to areas where it's hard to get workforce, so things like the after hours. So there's a specific exemption for people working outside normal hours. Where it's tied to a training program. And so if somebody, for instance, was participating in the Australian General Practice Training Program, the fact that they're on that program, if the college determines that they need to work in a location, they will get a class exemption to Section 19AB. So if they're on the college program and the college believes that it's necessary for them to work in an inner metropolitan area, for argument's sake, the system allows that to occur. The other exemptions generally relate to the location and the environment that a doctor's going into. An alternative, the only other area is what's referred to as the discretionary exemption, and that relates primarily to characteristics of the doctor which would preclude them from working outside a major metropolitan area, and the types of issues that arise there. If a doctor had a child with a significant disability that couldn't be treated effectively outside a metropolitan area, that's considered as a ground for them to receive an exemption. The interaction between Section 19AA and Section 19AB, as I said, is a cause of significant angst when people take citizenship or gain permanent residency. Prior to gaining residency or citizenship, having a Section 19AB exemption allows doctors to practice as non-vocationally recognised doctors. The moment that permanent residency or citizenship is achieved, that ceases, and so they become subject to 19AA and therefore have to be on a fellowship.
Stuart. Thank you.
Yep, a fellowship program or a workforce program. Now, the number of workforce programs has diminished considerably. At the moment, there is potential to get or to participate in what's called a 3GA program if you're working for an approved medical deputising service. So these are medical deputising services that have entered a deed of agreement with the department, and they are allowed to engage non-vocationally recognised doctors to provide deputising services. That pathway is gradually becoming or ceasing to exist. The other 3GA programs are all programs related to training and processes to get towards fellowship. In terms of Section 19AA, there's no grounds for review or appeal. In terms of Section 19AB, if a doctor in applying for a Medicare number needs and seeks a Section 19AB exemption and it's declined, they can seek a review. That will be done within the department, and an officer senior to the officer that made the original determination will review that against the legislative guidelines. If that's declined and the doctor involved or their employer believes that it's an unreasonable decision, there's provisions for the matter to be raised with the Administrative Review Tribunal, and the tribunal has the authority to remake that decision. At the moment, there was a review of Section 19AB, Section 19AA, DPA, DWS, and the Monash Modified Model, which was completed and published in October last year. The recommendations of those reviews are currently being worked through, and some change can be expected, not so much to the legislation, but to the operation of exemptions and to the tools that underpin decision making, so the distribution priority area, the district of workforce shortage, and the Monash Modified Model. We're currently undertaking a large body of consultations around the district of workforce shortage, which relates to non-GP specialists, and considerations being given to how we deal with changes to the distribution priority area. If people require any additional information, there's two email addresses you might want to use. The first is 19aa@health.gov.au. If you have questions, and send them there. We generally get back to people within 48 hours. And if it's in relation to 19AB, use the 19ab@health.gov.au. And again, we seek to respond within 48 hours. Thank you.
Thanks a lot, Stuart. That was great. It was really interesting hearing about the history of 19AB and 19A and how it all sort of got started. You sort of sit around these and be like, oh, where did this all come from? But that gives a bit more context. That was great. Thank you very much. So just letting everyone know is that Stuart actually sent us a lot of this information in writing as well. So we will be, similar to Christy's slide, we'll be sending out information with a lot of this information, including the contact details down the track for you guys, so you can refer to it. So lastly, last but not least, I guess we'll present Dr. Laila Shah and hand over to her. So as somebody who's been through this entire process and relatively recently, I think she's got a wealth of experience as to how it actually works from the other end, interacting with Ahpra and the department on these various sort of processes. So thanks, Laila.
Hello, thank you for the introduction. And I'm really overwhelmed that CHN has invited me to share my experience and my journey. To be honest, it is very critical to say that it takes quite a whole lot of years that I have come to this state that I can present. I will share my presentations. Is everyone able to see the slides or not yet?
Not
yet.
Okay, let me just can you see now?
We can see the slides, but it's not in presenter mode yet. There you go. Perfect.
Okay, all right, sure. So I will just start with that I am currently a GPT-3 registrar with the RACGP, and I got selected in the cohort 2021 and started in February. So how I got here is quite a bit of a roller coaster journey. I would say that initially I started like any international medical graduate would. I registered myself with the ECFMG and got my international degree recognized. And it does take a little while. You can give it a few months. Nowadays, the process might be a little different than when I did it. It was back in 2015. So that's quite an old story. Booked my exams, prepared for the AMC 1. And that was with the help of some peer support, guidance, which I think is one of the most important thing when you're trying to settle as a doctor in a new country, you know. So it was a little challenging on my particular story is that I had a 7-month-old child to look after as well. So I took a little while to actually set those exams, but generally on average, it takes like 4 to 6 months of preparation that you can actually set the EMC exams and get through it. So that's the first step. The next steps, like mentioned in the previous presenters in their slides, were the English language competency and looking for work, which could be through the limited registration, or it could also be by sitting the clinical examination and getting your AMC certificate and then applying for provisional registration. For all of these, of course, the requirement is the AMC certificate first and how you get it, and then you sit the English language exams. There are quite a few different sets of exams which are available, which is the IELTS, the PTE, and the OET. And once you get through that, of course, the challenges are not over. You have to do certain other things in order to satisfy the Ahpra to give you the required registration that you are after. So what I did was that I got my English language exam done, my AMC 1 done, and I thought that I was eligible for limited registration. So let's give it a try and see how I do in terms of applying. Actively applied for 6 to 12 months and got rejections. So of course, people do get disheartened by this. So I thought, why not? Let's sit the clinical exam and see if I can do that. And afterwards, I will give it a try again. So I did that, and unfortunately, I failed. And that was the little setback in my journey, but it did not let me stop, hunting for the jobs. I did not give up here. I continued actively applying because I was still eligible for limited registration. And I had heard some success stories from some of the peers that, yes, you can get a limited registration job in Australia with the AMC 1 and your English language exam if you do recency of practice. That's what sort of clicked. And I went back to my home country, which is Pakistan. And I did the recency of practice and was able to tick another box and do lots of CPD activities to tell and satisfy the board that, yes, I was actively trying to, update my CV and work towards the pathway to be working. There you go. During COVID time, the miracle happened. I got a call from the GMO pool saying that we've got the slots available for the limited registration. And here's one thing that at that time I did not try to attempt the clinical exam yet again. So I was quite surprised, but at the same time, quite happy as well. And I started working in Canberra Health Services. And it was, of course, a rotational job. So I had only internship back in my home country. So I needed some peer support here as well, because it is quite challenging when you start in a new country. Their health system could be quite a lot different from yours. And again, my fellows helped me. I was able to complete all my assessments. And now was the time to think that, what do I do now? Should I do the clinical exam because I've worked in the health system now? I would be able to pass it because most of my fellows were. Or should I do something else? Because it was COVID time. There was quite, of course, our challenges never end. So in COVID, the clinical waiting list was like almost 12 to 18 months to get an exam date. So I rather chose the WBA, and the information is available on the AMC website. And I got accepted into two New South Wales hospitals. Having said that, ACT is one of the state which does not offer the WBA program. So if you're looking at options, you have to look at other different states. So when I did my WBA, that was by the end of 2021, and I wanted to see what, and from here onwards, what do I do? I really liked working in emergency, and I continued to work in emergency for 2.5 years. But having said that, emergency is a quite competitive field. Plus, the working hours are crazy. And that's why I chose to work in general practice because of the work-life balance, because of the flexibility, the great diversity. So before getting into the general practice training, I did a little bit of preparation to organize myself. And that is what you need in order to, for any of the programs, whether it's AGPT, FSP, whether it's the ACRM, you need a little bit of research. So I started attending GP sessions, something similar to this. And I did my preparation, I sat my exam and got accepted into the program. So let me tell you a little about what are the requirements for the IMG to be able to be accepted in the AGPT program. Number first is your AMC 1 and 2 or an equivalent WBA in order to obtain your AMC certificate. After that, you get your general registration once you have completed the 12 months of supervised practice, and it should be an unconditional general registration. Now, because there is a set diversity that you see of different patient groups and demographics, they want you to have certain co-rotations be completed. And this is what helped me, is that when I was deciding, this is 3 years in advance to when I started my training, is that I did my emergency term. For the pediatrics, I counted 2 of my emergency terms because it had at least 20% presentations of the pediatrics. But of course, for surgical, this is a common misconception that yes, obstetrics and gynecology is considered as a surgical term. I had this idea as well, and I did that, of course. But then I had another term, which was orthopedics, which helped me get through the core terms. So core terms is something that you need to have as a something that will be ticked off when you are a part of the AGPT training program. Now, and I will tell you a little later why and when you can actually claim your prior experience as well. Of course, anyone who is an Australian or New Zealand citizen or a permanent resident is the one who can actually be accepted into the AGPT program. So that's another challenge as well for international medical graduates. I was on a spouse visa, so I did not need that, but some other people who are seeking and coming on work visa would definitely need this as well. Now, of course, I worked more than 4 years before getting into the training. So I thought, why not try the recognition of prior learning and get my training count towards my GP training. So what I did was that during my whole previous years that I worked in the hospital, I collected and kept organized my supervisor term reports, my term assessments, the hospital letters, the reflections, the support letters from the directors and things like that, because it was going to be helpful when I prepare to apply for the RPLE. There's a link attached here where you can access all the information for the AGPT RPLE. And here's why you need it, because as an IMG, you're already struggling. There is a lot of...
Sorry, Laila, that's 10 minutes.
Yes, that's all right. I will skip through a few. So yes, as an IMG, as you can see, there are lots of challenges, and you need some time to be able to do all of those things. So if you can cut short your training time, that is why you need RPLE. Of course, there are certain things that can help me, which helped me as well as other fellows out there, which is good mentorship and networking, which is important. I was a part of CHN right through the beginning, and it helped me connect with other people as well. GPRA has got good resources for the IMGs particularly. Hospitals provide education sessions on when and how you can join your GP training. And there is an AGPT handbook which is out there, and you can access it as well. Plus, there is lots of social media support groups as well, where people ask so many different questions, and we are always helping our peers as well. And I will finish it with that we are stronger together than we are alone. So I am very happy to help my fellow IMGs get through, and if they are interested to join a GP training, we are really in need of good GPs. Thank you.
Thank you so much, Ella. What an incredible story of perseverance and persistence to sort of get to where you got, get to the position you're in now. Well done.
Thank you.
I don't think I'd ever heard your sort of full story from end to end. And I think a big part of it is the testament to how organized you are, because even a lot of local medical students or local graduates as well fall into the trouble of not having kept their supervisory reports or all of those things in their early years, and then they can't claim for RPLE, or they haven't met the requirements for RACGP and other colleges as well. It's not just all RACGP, it's a lot of training programs. They haven't researched it early on enough. But you need to actually do that research before you sort of start your rotations while you're in the hospital year, so you actually have the relevant requirements, the prerequisites for whatever training program you're going into. So know what the programs are.
Yes, I do agree with that. And with RPLE, there's one useful tip, and that is in terms of when you're doing the application, try to reflect the terms in a way that it has helped you prepare to enter into the general practice training pathway. That is how your application would be much stronger and be readily accepted.
Great. So I think we've got about 10 minutes or so left. And I guess we can open up now to questions from our audience, and Kat's gonna keep an eye on this and help moderate or just throw the questions out to our very panelists.
Alrighty. Thank you so much, everyone, for your amazing presentations. We've got a question coming in. Is it necessary to work 3 years before entering into the GP pathway? I think this was from your presentation, Layla, when you mentioned the 3 years before entering the GP pathway.
It is not necessary. It only needs that you have to have the 12 months of supervised practice. If you're able to get the rotations, the challenge is getting the rotations, the right ones. When I was working, I got 2 rotations in that year, and I was being told that I cannot get more of the GP rotations, and I have to try next year. So that's a little challenging and practical as well. That if you're able to complete your rotations, why not? You can apply earlier as well. And for me, it took a little longer because, of course, I wanted to get more hands-on experience before I can actually go into the general practice. Because in general practice, you're in a single room and you're very independent, and you're sort of not very well supported the way you are working in the hospital as well. You've got lots of seniors there. But in general practice, you're in your room, you have your mind, and you have to think. So I wanted that experience before I can actually enter. But it is not necessary. If you can get with 12 months, you can get all the 4 core rotations. Why not? At the end, if you've got your general registration, you can straight away apply for the AGPT program.
Thank you, Layla. A question about where can we find the recording for this session. It will be uploaded to our YouTube channel after today, and you'll be sent a link to your inbox.
So, Kat, I've just posted the link to CHN's YouTube channel on the chat box as well.
Perfect. Thanks, Adnan. The next question, it might be for Layla or Chrissy. How can you enter the GP practice if you have a clinical gap?
So I can talk about the requirements for registration, but I'm not so across the requirements to get into a GP training program when there's a gap in practice. So the requirements for registration do depend on the pathway you're in, and just going back to the previous question, there is a requirement for a minimum 3 years of general practice experience if you're seeking registration in an area of need to work in general practice. It's the only pathway that requires that minimum time. There is, to get into general practice with a recency of practice gap, the board does consider that, but it doesn't prevent someone from applying, provided they have kind of worked on how they're going to address that gap. So there is a template available called a professional development and re-entry to practice plan that you can complete with your supervisor, which outlines how you're going to address, the gap in practice, what CPD, what additional training that you may wish to undertake, and to work with your supervisor on how you're going to do that. And they may just look at what type of position, what type of practice, what available supports there are, and determine that they may require different types of supervision. As I said in my presentation, generally they would expect someone with a recency of practice gap to need level 1 supervision, but I can say most IMGs working in general practice that have to complete a PESCI are seeking PESCIs for level 1 supervision anyway. So we do see a number of GPs start with level 1 regardless of gaps in practice. So as long as you're providing information to the board to support that return, then it's not for registration purposes, it's not a barrier. But as I said, I can't speak to the training, the entering the training practice program, the general practice training program.
Layla, did you have any comments about the recency for the AGPT program?
I would say that it's a common question. Yes, I did recency as well because I had a gap of practice of more than 3 years. But during those 3 years, I was actively attending the CPD sessions and also doing the online CPD activities. So I have had like a 50 hours per year as well. But still, because I wanted to skip the requirement of the re-entry plan, and because whether I would be offered that or whether there will be challenges in regards to that, I did the 6 months of recency of practice. But having said that, everyone's circumstances is different. And if you do not get the chance to do the recency, does not mean that you cannot get registered. There are some people out there who have only done CPD activities and they were able to be provided by re-entry plan from their hospital, and they were able to start that, or even in the general practice as well. So there are different options you can explore.
Thanks. I think that also answers what Shreya's question was, that you could sort of potentially use CPD and other activities to sort of maintain your recency while you're looking for jobs, if you're looking for jobs.
Brilliant, thank you. Another question, this is good for ACT because it's about MMM1 areas. It might be for Stuart. What about a level 1 supervision position in a DPA area? If I get my permanent residency during level 1 or 2 supervision in MM11 DPA, what should I do?
I can't.
Do you need more information for that one, maybe?
It would help.
Yep.
Okay, can I flag though that the level of supervision is a registration requirement, so that operates quite independently of the Health Insurance Act. To get an exemption to access Medicare in an MM1 is pretty challenging. That it would really come down to having personal characteristics which mean that your situation is exceptional. Having an illness that means you have to be near a quaternary hospital most of the time would be the type of ground, or having a family member that has that type of requirement. Otherwise, it is quite difficult to get a 19AB exemption in an area that's classified as Monash Modified 1 and in a metropolitan.
Thanks, Stuart. And we'll make sure to send a link to more information about those exemptions as well. This one's probably for Chrissy. Does the 52-week experience have to be after obtaining general registration?
No, that has to be completed before. So that can be completed with either limited or provisional registration. And then once you've passed that exam requirement, met the exam requirement, or have completed the WBA, you can then apply for general registration if you've completed that supervised practice component.
Brilliant. Thank you. And can you enter GP clinic without any GP exposure? And if you do recency in hospital for 6 months?
I think that's probably one for me too. In order to get registration to work in general practice without any general practice experience, you'll need to sit a pesky and be found suitable for the position you're seeking registration for. If there's no prior GP experience, it's likely the board will treat you as an intern and would require level 1 supervision for a greater period of time.
Great. And another one, what position should I apply with AMC 1 and postgraduate training completed in internal medicine in my home country? Is that,
I think
do you
that,
need
yeah, that's
more information for that one?
Yeah, I think I think that's about what positions they could apply for, which is probably outside of my remit.
I can talk a little bit about this. Is that it depends entirely on what you are interested. For example, if you are wanting to work in internal medicine, then you can apply for the non-accredited positions in internal medicine. But if you are someone who is coming on a standard pathway or a specialist pathway, then it's a different story. But most of my fellows who have had internal medicine qualification from their home country, they started by an unaccredited trainee position, and then they did their specialist assessment, and then they, after getting their assessment results, they were able to be offered a training position. But having said that, everyone's circumstances is different, so it entirely is your choice. But if you want to start on a standard pathway, usually the most basic is a resident medical officer position that you start from.
Thank you, Layla. There's another question in the chat box. Do I need to take the pesky exam before starting GP training? I have AMC 1 and 2 and a starting hospital rotation soon.
I can take that one. Yes, in order to be approved to work in general practice, if you're on the competent authority pathway or standard pathway, it sounds like that's the standard pathway because you've completed the exams. In order to work in general practice, you will need to sit a pesky first. That pesky needs to find you suitable for the position that you're seeking registration for. So you need to provide all that information to the board at the time you're seeking registration for, at the time you're submitting your application.
Thank you, Chrissy. And this one might be for Stuart. With level 1 supervision in a GP clinic, do we need Medicare numbers as an international medical graduate who is a citizen? So I think, yeah. So do they need their Medicare number?
If they want to access Medicare, I think one of the peculiarities of general practice is it's an exclusively private sector activity that relies on Medicare. If a practice was happy to take somebody on with level 1 supervision without them billing Medicare, it wouldn't be an issue. However, if the practice is expecting the doctor with level 1 supervision to be contributing to the practice with income, they would need to get a Medicare provider number. There is provision for what's referred to as a refer and request Medicare provider number, which allows referral to other services, request for x-rays, those sort of things, but it doesn't allow access to Medicare rebates. So I don't know if that answers the question, but it would really depend on whether the practice is seeking for the doctor to make a contribution to their income.
So I guess you could potentially, if you have general registration, be able to still work, but just bill privately, like not bill through Medicare, potentially.
Yep.
Yeah.
If a doctor is subject to 19AB and is working in a location where they cannot access Medicare or doesn't have an exemption, there is a legal requirement for them to advise the patient that there won't be a rebate available for that patient for that service. That's the only issue people need to keep in mind if they're working completely privately.
Yep.
Thanks, Stuart. We did have 2 more questions. I am mindful of the time though. Did we have a minute or so to ask one more question? Speakers?
I have to be somewhere else.
No, that's
okay.
okay.
Thank you so much for your time, Stuart. Really
you.
appreciate it.
Have a nice evening.
Thanks a lot.
Thank you.
Bye-bye. I
There's
think, Kat,
just,
if you just want to rattle off those 2 questions and then we'll close it off.
yeah, all right. Be quick. Kat, I think this one's for Chrissy about registration. Can we do 47 weeks of supervised practice in a GP clinic or only in the hospital to attain general registration?
That's a great question. The board does accept 12 months of general practice as the equivalent of hospital practice, including the rotations. So yes, that you can solely in general practice.
And there might be things like the pre-fellowship program or that kind of stuff where they can sort of go in that potentially.
But yeah, potentially,
yeah.
yeah.
And we'll send a link about the pre-fellowship program too. And can the 52 weeks completed during provisional registration be used for recognition of prior learning?
Is that to get into the
Is
general
that for the, yeah, it doesn't specify if it's for the AGPT program. Layla, do you know the answer to that one?
So if it is for the EGPT program that you're asking, it's 52 weeks. It depends on whether you have had the co-rotation requirement satisfied. You can certainly apply for it, but it depends on if you've got all the assessments available. For example, 3 months of ED experience and 6 months of ED experience in which one of it is counted towards pediatrics, and then also a surgical co-rotation, and then you've got the medicine as well. You've got all the 4 rotations covered, then certainly 52 weeks can be claimed. But if not, then they can tell you how much of your experience will be counted, and then it's up to you whether you want to pursue more in the hospital to actually limit that, or do you they can say that we can accept 3 months of your experience or something like that, up to like 12 weeks or 18 weeks, but the remainder has to be completed. So it is entirely up to the individual circumstances. Yes.
Great. Thanks a lot for that, Layla. I think we're gonna stop it there. So just want to thank all the guest speakers for taking time out of your evening, but also all the attendees for coming out and actually spending time in the evening to sort of learn more about this process. I think there will be an evaluation survey sent out as well, and we'll send out slides and the recordings as soon as they are available. But thanks everyone for your time. If you are a doctor needing CPD, I guess you could claim this. You can self-report this as a CPD time for an hour of webinar, and you can sort of do whatever platform you use to sort of lock that in as well. Thank you all again.
Thank you.
Thank you, everyone.
Thank you. Bye-bye.